Hello, everybody. Welcome back to a new KinetoDidactica podcast. My name is Bogdan Goga. I'm a very passionate physiotherapist. I really love our job. And one of our mission is to help develop this wonderful profession. So with me today, it's Sakis Adamidis. Thank you, Sakis, for accepting again our invitation to talk about our wonderful profession. Well, something that I think you know, maybe you do not know about our distinguished guest, is that he is an international Bobat instructor recognized by invitat, which is the Society of Bobat Instructors. Also, he is a PNF instructor, also a mulligan instructor. So Sakis, free of the well-known, let's not say the most known, but free of the well-known concepts that we use in physical therapy, which is the best?
First of all, I'd like to, once more, to thank you for the invitation. I'm very happy to be here again in Bucharest. Thank you very much. So I go directly to answer to your question. First of all, I'd like to say that you forgot to mention about the IPNFA also associations and NCTA also associations, because everything has associations. Okay, so I would like to say that which is the best? I got this question many times from people, participants from the courses, and actually I don't have a straight answer. Which is the best? None of them is the best. Because what is the most important? The most important, and I agree with you, is the physiotherapy itself. So all the concepts, the profession, and the science. Yes, this is the most important. And all the concepts which exist, just try to help on this direction, to help to make the science and the profession better. Yes. So maybe you can ask me why I choose to become in these three concepts. And from that, I can answer better. I would say it's because these three concepts for me combine many things. Because first, let's start with the PNF, because now we have also the PNF course here. The PNF, it's something which can fit to almost all patients.
Is it correct to say PNF is like the oldest from the three concepts, or maybe it's like the oldest concept in physical therapy?
No, I would say that Bobat and PNF, I would say, started almost together.
But they are both like the oldest.
These are one of the oldest, yes.
Manual therapy concepts?
Listen, it's one of the oldest which are still existed. Both are existed now already 70 years. And it means that if you exist so far, so long time,
if you
survive, then it means that you do something good. And I think the secret on that is developing all the time and gets all the time new ideas, respects the research, respects the new information that comes from the...
You evolve.
Yeah, actually, we try to change. If you like to change, if you like to survive, then you have to change. These two things goes together. All creations, if they like to survive in the environment, they have to change. This is exactly what happens with these, as I name them, as the life concepts. So come back to the initial question, which is the best? I would say, again, none of them is the best, but you can get from all of them nice information which can fit to the patient. And the patient needs and expectations are the most important thing. And then if you do a good assessment, a good evaluation, and you follow a nice clinical reasoning, then you can get nice ideas from each concept to use it for the treatment, for the treatment planning.
So what I get from what you're saying, so the key, or maybe the first stone, is the assessment.
This is true. Whatever you do in the physiotherapy, you should be guided by the assessment.
Well, that's really, in my opinion, let's not call it a problem, but it's something that we see it in our country, and I can say that when I was a young physio, because I will make 10 years this year, so I can call myself not young anymore.
That's true. 10 years experience.
Not big experience, but not young anymore. I didn't do so much assessment, or I didn't do non-assessment. So the patient will come with a diagnosis. Maybe he'll come directly with the indications from the rehabilitation doctor and start working. And we see this still, that in our country, there are a lot of physios, I cannot say the minority of majority, they don't do assessment. So
yeah, trust me, this is not happen only here. Okay. This is a common problem everywhere. Because it seems to be easier for the physios just to use kind of recipes. Yeah. So when they know that I have a stroke patient, for example, and then I know how to develop my treatment because I know, because I've just based on some experience I have from previous patients, and then I have some steps. Step number 1, step number 2, number 3,
walking,
number 4.
Gait, working the hand.
Exactly. Some exercises which is common with patients doing in the bed, some other maybe on the mats, some other maybe on sitting position or standing, and that's all.
Or maybe with low back pain doing
the same
exercise.
Could be the same, yes. Yeah. So many physios do that. And of course, if you ask me why they do that, because this seems to be the easy way. Yes, I know some, let's say, exercise which I trust. I have some own experience which I feel okay with that. And it's true that many of these treatments have good outcome.
Yeah.
Yes. So that's why if you ask all these physios, they say, listen, when I see my patients, I have results. Why should I do something extra? Why should I put some more effort to that? Yeah. So, but this is not true. This is not true. Because assessment, and now I'm talking about the physio assessment, is different from assessment that the doctors do. Because before you said the patient goes to the physio, comes to us, and he has already a diagnosis. Yeah, but what diagnosis is this? He's coming, for example, with low back pain. What is the diagnosis? Most of the cases, the diagnosis is non-specific. Low back pain. Or maybe the patient has some hernia or some degenerative changes, which you can see in everybody. It's not necessary to be a patient to have degenerative changes. We've seen that from evidence. We know already that. So this kind of assessment that comes from the doctor doesn't help us. We need to clarify some things, important things in the patient based on, let's say, biomechanical assessment, which is very important, of course. And also, we have to see the patient from all perspectives. We have to see the needs, expectations, what really the patient wants to get from us.
But still, the patient has to go to the doctor and then come to us.
Definitely, yes.
You cannot come directly to us in countries like Romania or Greece.
Yes, in Greece, we have these cases that patients come directly to us.
Okay.
And in this case, you have to be much more careful. Because some of them, maybe they have some contraindications, red flags, like we call it in the manual therapy. So we have to be very careful on that. We have to examine the patient. And first, we should start with a good history taking.
Yes.
Because history means his story. We have to listen. And the best way to listen to the patient is to let him confess, to say it in his own words. Because many of us, we involve in that and start to ask questions.
Yeah. And sometimes we say, we know his problem. The second he walked on the door, I already knew what's your problem. Huh?
Yeah, true. So let the patient express his symptoms like he feels. And this is good because through that, you can get the information you need. If you need some more, you can, for example, specify by asking an extra question, but not start from the questions from the beginning. And this process is very important because when you listen to the patient, you already make in your mind a kind of, you make some hypothesis. And then it's the time which you start to do the physical examination. Yeah. Let me give an example. A patient with low back pain is coming and he says, and he describes in his daily life that every time he sits, prolonged sitting, when he's driving,
Yeah.
when he sits in his work, when he sits watching TV or maybe in a theater, he always has this pain. Yes, always the pain triggers him, or the pain becomes worse.
Does he have pain when he moves?
But, okay, this can be one scenario.
Yeah.
Let's say,
When
when he moves,
Mackenzie would say that it's a postural syndrome.
maybe it's a
not pain
postural syndrome.
moving, pain only when sitting prolonged.
Yes, but maybe when you listen to the patient, then you're gonna say that after sitting long time, when I stand up, I feel worse.
Yeah.
Though the first steps it's worse, so it takes me time in order to recover. And then maybe they will say that when I walk long distances, maybe I feel okay. It's much better. It's very common to listen these kind of things from patients. Then we know already. It's a little example, of course. You cannot just base only on that. We know already that flexion direction, maybe it's involving with the symptoms. So I know already in the physical examination what I'm going to examine, in which direction I expect to see symptoms. Maybe in a flexion. Yeah. So this is something which helps you to direct the physical examination, and you don't have to do all the protocol of the physical examination, you know. So the history helps you a lot. Yeah. So, and then of course we need good assessment, detailed assessment, in order to reach the real point of the patient and in order to make decisions. Because you said something before. After listening to the patient, you make hypotheses. A nice advice to the physios, because I'm a little bit more experienced than you, so I can give some little advices. Not a lot, but little advices. When you examine a patient, your tendency in the examination should be to exclude, not to confirm. This is very important and critical, because if you are all the time, you have a hypothesis in your mind, and you try to confirm, that drives you not always in the truth, in the right process. But if you try to exclude all the time, let's say you think that the patient is, for example, has weakness, try to exclude that he has weakness. The patient has problem with a hypomobility, try to exclude that he has high mobility. And if you cannot exclude, then maybe that fits better to the patient condition. This is a good process, general advice, I would say. And this is not only good for the physio, but also for the medicine. In the medicine, when you do this, you try to exclude, not to confirm. That's a good advice. Yes. But finally, this good assessment drives you in a more reasonable treatment.
Yes.
And this is
more efficient,
more effective. And this is what the patient needs for us. Yes, for us to be more effective and to be to come sooner to the result, not too late with this. Yes, because people trust us, people expect quick results. They have to work, come back to work, so they need the time. They don't have time to waste with us. So I have to be. That's why it's good to educate ourselves all the time, to follow the evidence, to follow new ideas, to know about treatment proposals, concepts. This is good. We have to educate all the time. Physio is a science which we have to develop all the time. It's very important.
I would like to highlight something, because I felt the discussion went in that way, but I know that we both agree on this thing. We need to work with doctors. We need to work with rehabilitation doctors.
Definitely. Rehabilitation doctors are very important part of rehabilitation. First of all, these are the coordinators. So once we have a patient, and especially in rehabilitation,
complex patients.
Complex patients. We have a patient with a multifactorial, multifractures. He had an accident, a car accident. He went to the hospital, and then after that, he needs rehabilitation. But he needs only our help? Of course not. So who's going to evaluate this patient? The rehabilitation doctor. He can put the priorities in this patient. He can direct this patient to which specialties he has to follow. And he has to be the coordinator of that.
Like a manager, a case manager.
Like a manager,
because sometimes, I've seen this, there is a confusion, not like confusion, but we put the equal sign between rehabilitation and physical therapy, which is...
It's not the same.
It's not the same.
No. Physical therapy is a part of rehabilitation. Rehabilitation is much broader.
Yeah.
For example, when we have a patient, a neurological patient, probably he has communication problems. Can we do anything about communication problems?
No,
very few things.
Speech therapist.
This is for the speech therapist. If the patient, we have the occupational therapist, we have the psychologist, we have the social workers. So all this has to be coordinated.
Yeah.
And the rehabilitation doctor is responsible for that. He has to evaluate, he has to exclude that the patient has contraindications, he has to find out if the patient has any comorbidities, and he has to give us guidelines, he has to give us advices, what things we have to avoid, what things we have to watch in order the patients to be safe.
Yeah.
And sometimes they have good advices even for us. They can, because they evaluate the patient, they can have a very good, how to say, sight and knowledge, which they can help us for us to become better and to evaluate better.
And they'll put the diagnostic.
They put the diagnosis for sure.
Yeah.
The diagnosis and the prognosis is their job. It's not our job.
Yeah.
They are responsible for that. And many times when I'm working with in rehabilitation centers, because part of my work is this, I'm, let's say, a second opinion therapist in Greece, so I visited different rehabilitation centers. I never take any decision unless I ask the rehabilitation doctor, because he knows he has the overall picture of the patient. He knows everything about the patient, and this is his role, and he should take decisions.
So what we are saying,
all of us, we have to respect.
Yeah, I don't find another word now, but the assessment it's different between the assessment of the rehabilitation doctor and our assessment as a physio.
Definitely, because actually we just see only mostly the sensory motoric aspects of the problems of the patient, and we need to do some physio assessment in order to understand from these sensory motoric which are the most profound problem, in which direction we're going to help our patient. Yes. Okay, and I told you, some doctors, they have good experience, so they can help us in this direction. So we can communicate with them.
Definitely.
Yes, we can go and ask them. It's not a shame to ask somebody to give your opinion, because he's a doctor, he has knowledge. Come on. And most of them, they have a good experience. They've seen many patients. And especially for the young therapists, they need to do that. And it's very good. And as I said, in Greece, I don't know what's happened here. By the years, we had, there was a bit conflict between the physios and the rehabilitation doctors. I never agree with that. Because first of all, we do different jobs. This is different, totally different job, which we have to cooperate. And yes, based on that, what we need to cooperate in the best way. And if you like to gain the respect from somebody, which is your partner, which you collaborate with him, or it's sometimes your supervisor,
your superior.
You have superior from you, then you have to become better yourself. Our enemy is ourselves. We have to become better as a physios, and to do that, we need to study, we need to practice, we need to see the research, and we have to respect the other's opinion. Yes, we have to respect the cooperation.
Yeah. So to just say our message from today's discussion, which was very interesting, was we need to make ourselves better.
Yeah, definitely.
In order to gain from exterior, we have to look in our interior.
This is very good. Very, very, very important. Because if you really like to get the respect from the others, then you have to become better yourself. Then the other respects you. Nobody has nothing against you. If you are a good physio, all people around, and especially the doctors, going to recognize.
Yeah, and all doctors want a good physio.
Of course, definitely. Because the doctors needs us.
Yeah.
And we have to see this from this perspective, that the doctors needs us. Because they cannot do everything. They cannot do our job.
Yeah. We need them. So it's...
Because, yes. And we don't try to replace the doctors, because sometimes we do these kind of things. We give some ideas about diagnostics, about hypotheses, but this is not good. Don't do this.
It's not our job.
It's not our job, and it's not safe for the patients first, and also for ourselves. And that's why then we lose the trust from them.
Yeah. And from there, all the fighting. Yeah, it's similar to Greece in Romania.
Yeah, I think it's similar. Yeah, I guess it's similar.
But we have also, I, for instance, with all the rehabilitation doctors I worked, I had a very good relationship.
Oh, yes. We should have good relationships.
Yeah.
Yes. Yeah,
because
that's true.
Sometimes I think we tend to forget that in the center of our work is the patient, not who's right and not, who gets the credits or stuff like that, It's the patient.
Yeah. If each unit makes his job on the best way, then the result reflects to the patient. And this is exactly what we have to think, everyone from our perspective. And we need a good collaboration, not only with the doctor, but also with the rest of the team. Yes. I have an example. It was once a speech therapist, he's complaining to me as a physio that sometimes, in a discussion we had, that sometimes we do a lot of intensive work around this area, because we give resistance to the shoulder, to the neck, to these kind of things. The patient gets stiff.
You have irritation to all the muscles.
Yes, and especially neuro patients get some spasticity on those muscles, because we have to know that the tongue, for example, our tongue consists of 17 muscles, which can be affected by what we're doing. And that makes the work of the speech therapist very complicated. The patient afterwards maybe cannot swallow, cannot breathe, which is vital function. It's not just about his posture, whatever. Yeah. So because I think, and this is something we have to change, the physios, we are thinking in a very selfish way. We think that we are the most important in rehabilitation, but we are wrong.
Yeah.
We're just a part of this chain.
Definitely.
And we have to do our job as much as better.
Every part is important.
Every part is important.
Yeah.
But we're not the superior. Don't think about it.
We should see that we should maybe start learning better to work in a team.
Yes.
And
this
sometimes is very hard.
This is very hard, yes. And especially with countries who
I don't know in Greece, but in Romania sometimes, if you do not agree with me, you're against me, that concept.
Yeah, that's why I told you, we feel ourselves, for ourselves, we feel almost like selfish. This is our behavior.
Yeah,
we think
I
that we know everything.
This is something also coming from, because we are in a full process of development, our profession. And we want recognitions, we see recognition and we want it, to happen to us.
Yes. But this is, each person in each profession likes to see that.
Yeah.
But we have, yes, it's good. It's good because if we think like that, then we progress. So we should think in some way like that, but not really in the way we do that. Because we think, as I said, too selfish. This is what I see in our profession. You have to change this. You have to work more as a team, as we said.
Yeah,
I agree with that. Yeah.
So work more in a team, assess more, and better.
Yes, and better.
Our
clinical
patients.
reasoning. Whatever we do, we have to do the clinical reasoning.
Yeah, this is something that maybe for some of us, for me, was 3-4 years ago, a new concept. How would you define clinical reasoning?
Yeah. So I would say clinical reasoning is I would say in a simple word, in a very simple way. From tomorrow morning, every time we make a decision to do something with a patient, we should ask ourselves, why should I do this?
Yeah.
Listen now. Maybe you don't have the right answer.
Now.
Yes.
In that moment.
Maybe you make a decision and you think, okay, I like to improve this thing, and what you choose is wrong. But then you're going to see it in the result. Then you see that you didn't really got your goal. So it means that if you go back, you have to change something. So what is the worst? The worst scenario is that if you do things without knowing why you're doing this, it's just because you used to do that. It's a habit.
Yeah.
I know that in a stroke patient, or maybe
this works for it.
This works. I have to do 1, 2, 3, 4, 5 things. This is what I know.
And 9 out of 10 patients, they go good, and 1, come on.
Yeah.
You cannot heal everybody. Huh?
Yeah, but sometimes a patient goes good because only you see that.
Yeah.
This is another trick.
Yeah.
So ask yourself all the time before to an action.
Yeah.
Why should I do this? Even if you have a wrong answer, just that you should have an excuse. If you answer to that question to yourself, then do it. Whatever is that.
Yeah.
But if you don't have an answer, or if you don't ask, don't do it.
Okay.
Try to change a little bit like that. This, for me, is the clinical reasoning.
Yeah. So why we do it, it's more important than what we do with the patient.
Yes. Because
we tend sometimes to be on what we do with that patient.
No. Yes, exactly. Why we're doing it's much more important, and it comes from the assessment.
Yes.
If this can be answered from the assessment, then it's okay. So I would like to put you this clinical reasoning in an easy model, let's say. So the first step is what the patient can do. Watch the patient, because there is a tendency when you see the patient, we just have the tendency to see the negatives, what the patient cannot do. And sometimes, but this doesn't help.
Yeah, and
it's negative,
many of the cases we tell him, this is why you come to me, because you cannot do this, this.
Because we already make decisions about him.
Yeah,
that's just too early. So what this patient can do, and maybe in this we can see some little problems.
Yeah,
in observing what he can do. The second, how he's doing is important. Observe, see how he's doing, and then once you observe, then you have to go to why he's doing like that, and then try to make hypotheses, which, if it's possible, to test them in the way I told you, in order to exclude, not to confirm, and then you maybe can go easier to make a little prognosis. Because you have to know before we start the treatment how the patient gonna be in 5 sessions, in 10 sessions. Not just, it's not a good idea just to start a treatment and the treatment never stops.
Yeah,
because it's common. In Greece, for example, we have cases which when a therapist finds a stroke patient and starts a treatment, when this finishes, when the patient cannot afford anymore. But this is not right. You should have a goal.
Yeah.
Physio treatment should be with a goal.
Therapeutic goal, and also what the patient wants.
What the patient wants, yes. These 2 things has to be joined in your mind, yes. It's like, in the business planning, they use an abbreviation. Yeah. They call it as a SMART.
Yeah.
SMART.
We know. Specific, measurable, achievable, results, and time. Yeah,
exactly. We should follow this. This is the clinical reasoning. This is the best clinical reasoning, if you like to find the definition about that.
Yeah. Well, Sakis, thank you so much. It was
you're welcome.
A wonderful discussion.
Yes.
I can only wait for our next discussion.
Okay.
Thank you
I promise we do it soon.
For the wonderful things that you come to share with us.
Okay.
And
You're welcome.
We are waiting for your comments and ideas, if you would like, about
questions.
Yes. We are open. Objections, because the best part is the discussion afterwards.
Oh yes,
the discussion after this discussion.
Of course, That's true. When the people listen this, make reflection, and then they come with new questions. Maybe the next day, whatever.
And this is how we can all evolve.
Yeah, exactly.
Thank you so much, Sakis.
You're welcome. My pleasure to be here.